Becky. Yes, Kwe Kibuktuk. Salut d'Halifax. Hello from Halifax. Kibuktuk means Great Harbor, and that's where I'm coming from. It's the traditional Mi'kmaq name for what we now call Halifax, which sits in Mi'kma'ki, or the traditional and unceded territory of the Mi'kmaq people. So, Upchilasi, bienvenue, welcome to one and all to our talk today. We have a great talk today. And it actually builds on some fantastic talks that we had from the last couple of years. I know about 3 years ago, Adil and I had a wonderful speaker and really introduced some. It's at the time, the unfortunate time nationally, when the residential school discoveries were happening across the world, across the country. And so we're really all being educated on some shocking things that I, for one, was not aware of. So today we continue on that journey so that we all are more sensitive to how we work and move and really facilitate for the absolute best care of all our patients. And that's very importantly why we have Sheri Hundseth, who's with us today. So she's Director of Indigenous Relations and Community Engagement at Providence Healthcare in BC. And Sheri comes to us today as a Métis and was raised in Region 1 in Lac La Biche region of northern Alberta, although she's in BC now, which is Treaty 8 territory. So lovely, lovely, lovely to have a speaker who has lived it as well as is working in that space professionally. We'll get some fantastic information today to really help us all. So Sheri's the Director of Indigenous Relations and Community Engagement at St. Paul's Hospital, so Providence Healthcare. Prior to coming to Vancouver, Sheri spent 6 years with Covenant Health Canada as the Manager of Learning and Development, and has worked for many, many, many years in organizational development and change management. Throughout Sheri's career, she's specialized in training, relationship building, coaching, and leadership development. And I love what Sheri just shared with us, like just before the meeting, is she's working so that she works herself out of a job. So love that sentiment that hopefully we all can learn today and all grow together as a full country of nations and peoples coming together to share fully and properly as Canadians. That's my personal view. And I really look forward to Sheri's talk with us today. So she's going to share for us today in her current role some knowledge and wisdom that she's gained over the years. And she wants to share a PhD's work to map Indigenous patient journeys, to identify opportunities for improvement within the healthcare system. And if we know that, then we can see all our little perspectives as to how to add to that positively to help achieve that. I think with that, Becky's already reminded folks, please, please, please use the Q&A box, which we'll monitor and we'll ask those at the end. Today is a smidgen longer talk, which is great. There's so much information to pack in. So it's going to be like an hour and 10, hour and 15-minute talk with the questions at the end. And I think with that, Sheri, lovely to have you today. Floor is yours.
Great. Thank you, everyone, for joining me today. As Michael stated, I am Métis from Northern Alberta. I actually typically work and live as an invited guest on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. Today, I'd like to share with you that I actually am away from the territory that I have been living on. I'm an uninvited guest on the traditional unceded lands of the Lekwungen, including the Songhees and the Esquimalt First Nations and the Wasenek First Nations as well. Very happy to be here in this very rainy territory today. So I'm excited to share with you. Michael was talking a little bit about my own experience. Yes, I will share some information about my own experience somewhat. The talk today is going to be very much about the experiences directly from Indigenous patients who have experienced healthcare within BC. What I really want to throw a disclaimer with, though, too, is this presentation really does cover some topics that aren't limited to colonial violence, racism, and specific racism and equality. some of this information can be really hard to hear, especially for anyone who is Indigenous. So anyone who is Indigenous, please note there are some numbers that you can call if you are feeling very unsettled by the information that I shared today as well. So today, and I apologize, I left a word in here. We're going to identify recurring issues in healthcare environments. This isn't just perinatal, including Indigenous-specific discrimination and racism. We're really going to be talking about the importance of Indigenous cultural safety in healthcare and some insights for providing more culturally safe care. What I've done is I've worked with, and I'll talk a little bit more about the details in this. I've worked with over 68 patients in this realm at the moment, over 2,000 for feedback in healthcare in general, but for the patient journey maps, about 68 patients now, and pulled the information that will be helpful for this group to look at in relation to what your roles are within the healthcare system as well. Really want to reflect because of that on priorities that can happen for change. And this really truly has emerged from the patient experiences. And I'd really like during this whole talk for you to reflect on your own cultural safety journey and take a look and identify opportunities to take action as well. So first things first, I want to talk a little bit about what patient journey mapping is. And out here in BC, typically what we hear from folks that hear about patient journey mapping, they see it from a clinical perspective. So typically it's physicians or it's healthcare providers that are actually talking about the journey that the patients have gone through. Here we flipped it on its head. Patient journey mapping really is a method that we've come up with to ensure that there is a culturally safe method of allowing Indigenous people to feel safe sharing their experiences. Oftentimes, Indigenous people feel like experiences will be utilized against them. So we created a method that has really allowed people to share in a very honest way what they've experienced in the healthcare system. This process really is, and you'll notice that I put the word in brackets here, really is supporting the building of relationships. Historically and even today, we are still experiencing a ton of anti-Indigenous racism, and it really is important to take a look at how we can build relationships. Patient journey mapping is also gaining prominence. I've actually worked with or spoken with a number of groups across Canada that are wanting to utilize the same methods to be able to gather and share patient experiences to really actually understand how they're interacting with the healthcare system and to come up with some truly beneficial and realistic ways to improve the healthcare system as well, all coming from the patient's point of view. Patient journey mapping really is informing and guiding the guidance for continuous improvement that we're doing here at Providence Healthcare as well. And it is allowing us to provide more culturally safe care for Indigenous patients here. So the reason we're doing this, we really wanted to make sure that people were seeing the current realities of the patient experience. Often when we're talking about Indigenous cultural safety, I work with a number of groups, teach over at UBC, and teach with a number of organizations across BC as well. And often they ask why they're doing this because they feel like this is stuff that has happened. Why are we still talking about it? It still happens every single day. I work with a colleague who is an Indigenous view on complaints that come in through the system. We work with Indigenous patients every single day, and we hear ongoing challenges that are happening as well. Really important that we're collecting and using this patient data for continuous improvement. We also allow the patients, they take a look at the information that they've shared with us, review it, let us know if there's anything else they want shared, and they are very aware of how we are utilizing this information. They give us permission to do that as well. These results also tell us how we're doing. It really is about a continuous realm of improvement. So continuing to do these patient journey maps has been incredibly important because are we actually improving what we said we were going to improve? They also guide us and they let us target our efforts in a really precise manner. And these maps and findings, and I hope today is another piece of this, is we hope that by sharing these, we actually inspire action and support change. So I've been working with patients in this realm and doing this specific work since November of 2022. And as I had stated before, we've worked with over 68 patients who have been very generous to share some sometimes incredibly traumatizing and horrific experiences within the healthcare system. The Indigenous Wellness team facilitates the process, and we have a graphic facilitator that we work with as well, who has worked with a ton of different Indigenous organizations. Myself being Indigenous, I am the interviewer, and I work with the interviewees. They are given the opportunity to bring in any support people, elders, knowledge keepers, anybody that they would like to have provided their liaison support, whatever feels safe for them, and we do them in an area, space, place that feels safe for them as well. So this is very patient driven. Patient selection process, initially when we started doing this work, it was very much related to convenience. I work with a really wonderful team of Indigenous wellness liaisons who were able to connect with a number of patients who wanted to provide feedback. Started working with a number of physicians who knew patients who had experienced some pretty horrific things within the healthcare system and or wanted to share some positive experiences as well. You're going to hear that mixture of things throughout. What I'm very happy to say now is at first, it being convenience, it became a bit of a snowball. People were feeling really safe within the process and started sharing names of others that wanted to share their experience as well. And it's now become incredibly purposive. We're able to reach out to people for very specific areas to receive feedback as well. The process is driven by an open-ended question. I don't drive the process. This isn't about me looking for responses. This is about me asking, what was your experience like in healthcare? And then the patients actually drive the way that the maps go and the information that they feel comfortable sharing as well. And then we analyze the transcripts and identify different key themes and implementation priorities. So who participated? I've pulled a selection of patients here. Overall, though, we've worked with 68 Indigenous patients who've received care within the healthcare system within the last 36 months. These patients range in age from early 20s to mid 80s, identify as male, female, or two-spirit as well. So a number of folks from the LGBTQIA2S+ community as well. Most of these patients live in Metro Vancouver, the Greater Vancouver area, or rural communities within BC. And then we've also had some experiences with rural communities in the Yukon and Northwest Territories, as BC does support these territories as well. The patients visited a number of different areas: perinatal, the emergency department, mental health, substance use, surgical, urban health, ICU, radiology, cardiology, family health, renal, inpatient and outpatient. It's been a really large spread, so it's been wonderful for us to be able to share this information with the different units and departments to start making improvements in their areas. Through this work, what we've noted is there have been a number of indicators that have come about. There's over 260 indicators that have been identified that can actually support Indigenous people to have a better experience in healthcare. These 6 are the 6 that have actually come out as the most significantly identified through the patients that we've worked with. The first being respect, and within respect, just feeling like when they walk into a facility, they will be respected as a human being. And over again, so many of the patients have stated to us that they just want to be treated like a human being when they're experiencing healthcare. Identity, to be able to feel like they can identify as an Indigenous person and know that they are going to receive the same or better care, right? Not what we have historically experienced in areas such as Indian hospitals and with the ongoing anti-Indigenous racism that permeates society here in Canada as well. Empowerment and equity, to be able to feel like you are an equal partner in your healthcare journey, that you actually have the opportunity to ask questions, to make decisions, that you aren't just following an authority figure in what they have stated that you require. Safety, to have to ask for safety, to feel safe when you're actually walking into a facility, to feel like you won't be experiencing horrific things, violent interactions, or again, just anti-Indigenous racism. Relationality, and this is a question that I often ask each group that I work with. How long, when you go into a doctor's appointment, do you actually see your family doctor for? And typical responses that I hear are anywhere from 2 to 10 minutes. When you're already feeling unsafe within the healthcare system, how relational do you feel with your physician that you're working with if you're only seeing them from anywhere to 2 to 10 minutes? The last interaction I had with my physician, not the last, the first interaction I had with my physician before we started having conversations about this was when I was experiencing a rash on my wrist. And I went into the clinic, waited for him for about half an hour to show up into the room, and he was there, looked at my wrist and gave me a prescription. Didn't ask my name, didn't introduce himself, didn't say anything. When I took a look at the prescription, he had already left the room and realized it was something that I was allergic to as well. So I had to speak with the pharmacist to actually get an appropriate prescription. This doesn't feel relational. I wasn't able to have those conversations and could have received better healthcare from him if that conversation would have just been longer. And then reciprocity, being able to have a back and forth conversation so that you can actually know more about the system and understand that people are actually interested in you as a human being as well. So I'm going to jump in, and what I'll state to you here is I typically, with the patient journey maps, actually typically always read the words directly from the patients. So what you'll notice is that I will be reading their experiences as this presentation continues, and then there will be breaks in between where I speak about what we've discovered through the information that's been shared related to these particular maps as well. This map in and of itself was very unique in that it actually involved 4 patients all at once. They had requested to be able to share information all together. These 4 Indigenous participants had all experienced healthcare within the system, oftentimes as without home individuals, so had lived on the streets down in the downtown east side here. They opted to do this together because it allowed them to feel that they could really support one another and allowed them to feel like they were able to advocate for one another while we were doing this work. One quote that really stood out when I was working with this group is, peer support and Indigenous liaisons have such a positive impact and help with guidance on the healthcare process. Advocacy matters. There is a need to support Indigenous peoples. People need to be treated with dignity in any context. We are the voices for those who cannot be here. This group in particular also stated that they would really like to see more familiar faces within the healthcare system. Why aren't there more Indigenous people that work within the healthcare system? Often now we have a larger, not large enough, but a larger team of Indigenous wellness liaisons who support Indigenous patients when they come into the facility. And allows people to feel like there is a familiarity there, someone who may actually understand their experience more. But they've really asked a lot of questions about why we're not seeing more Indigenous physicians, more Indigenous nurses, more Indigenous engineers that work in the faculties that you're all working in as well. When entering the hospital, our guard is immediately up, and we remember bad experiences that we've had in the past. Any person with lived experience who have lived on the street have been mistreated here. People avoid coming in because of negative treatment. People need to be treated with dignity. You need to make sure we are hearing from the downtown east side. It's so important. There's so much suffering. Almost all of the patients talked about security and the security services that surround and are working within the facility as well. Many had experienced some incredibly violent interactions with the security services teams. And we here in BC ask Indigenous self-identification questions. Are you Indigenous? So that people can actually access Indigenous supports. When asked, though, this group stated, I didn't want to say I was Indigenous, didn't feel safe, felt like they would be treated worse if they actually identified as Indigenous. One of the members of this group also stated, we worry about family members, partners in the hospital. We have no idea that they're transferred to other locations. My partner passed away before I could get there, and that was so hard and so unnecessary. I talked a little bit about Indigenous self-identification. It's so important to ask this question because there are Indigenous-specific supports that are available to Indigenous patients. And it's important for patients to be able to be connected in with those resources. Some of the patients are comfortable being asked, but many are not because they fear the repercussions. They fear that they will be discriminated against. So it's really important how people actually ask these questions. Some patients have been asked to prove that they are Indigenous. In particular, one that I worked with that was half Haitian and half Indigenous. And she was incredibly offended. I'll talk about that experience right away here. Some patients also spoke about the importance of continuing to ask throughout the healthcare journey, regardless of who you are. And if you are on site in some way, shape, or form, and you are interacting with patients, and you discover that maybe one of these patients is Indigenous, and you're hearing that from them, to be able to ask that question. Some patients are more willing, as they see their experience improving within the healthcare system, to answer those questions as well. And many patients actually reported that they were not asked if they were Indigenous and instead were found by the Indigenous wellness liaisons. We're asking that every single patient be asked that question. We don't all look the same. I'm often mistaken myself for being Italian or Spanish, anything but what I actually am as a Métis person. And in addition, many of the staff members don't know where to find the Indigenous self-identification information when somebody actually identifies as Indigenous. So aren't interacting with patients or ensuring that the Indigenous wellness liaisons are pulled down for support when they're working with patients. This next map that I'm going to share with you, this patient and her partner, two-spirit female from Healthsick here in BC, 31 years old, and received care at St. Paul's Hospital here in BC in maternity. For me and my wife, we had a different process from the very beginning. We live here in Bella Bella, so it's quite a ways. It's like a 6-hour ferry, a 5-hour drive, and another little ferry to get into Vancouver. So it's quite a ways to get back and forth, and it's also very pricey. We have a lot of supports here in Bella Bella. In terms of our healthcare system, they have prenatal and postnatal support. But with the complications of having twins, we couldn't have the babies in Bella Bella. We had some doctor's visits with a doctor, and we love her. She's great. She came down to Bella Bella once, and then we got referred to her. She was going to be our OB the whole journey long, so that was really exciting. She was super supportive. We had a hard decision on deciding whether we should transfer hospitals because we wanted Indigenous support. And that was really huge for us. We wanted our babies to be welcomed by an Indigenous midwife and a doula. Not all of the hospitals are connected to those supports, and not all of the doctors support those services. Before we got transferred to this hospital, there was also something very bothersome. I'm half Haitian and half Healthsick, and it was really frustrating. They're like, oh, you have status? It felt like they thought I was lying. There needs to be more sensitivity training around. You can't just ask people that. And they wanted me to prove I was Indigenous. They asked me to see my status card. And I was like, you're not taking my word for the fact that I'm First Nations. It was kind of weird to get the supports, to get the First Nations supports, knowing how many people are not connected in with their nations, but are Indigenous and aren't able to get access to prove that they are Indigenous because they've been without home, or because they were part of the 60 scoop or the millennial scoop. They were adopted out of their families or taken away from their families. It's incredibly important to be aware of the fact of how traumatizing that can be for Indigenous patients. Thankfully, we got connected with an Indigenous wellness liaison. She knew one of the elders that was able to help us. She really did go above and beyond for us. An elder did a ceremony for our boys, and it was really important for us to do that. With my wife coming to see me as often as possible, it was getting incredibly pricey, and I was lonely. So she tried to stay with me, but it was hard and it wasn't very comfortable. I was here for 6 months, and she said sleeping on that mat on the floor made her feel like a dog. Travel to and from the hospital. So many nations are on reserves that are away in very remote circumstances. Indigenous nations were taken away, lands were stolen from them, and they were placed in territories and lands that were unappealing to the colonial folks who came in and took them away from their lands. These aren't great areas. People don't want to live in those communities. I mean, the Indigenous communities are there, and they've created and made space for themselves on those territories. But it's really hard to access services in those areas. So they often have to travel really long distances to receive the care that they actually need. And it's very expensive to do so. So many patients have actually expressed concerns over the expense for family members. Here in Vancouver, the average hotel room costs about $700 a night. So to come and visit your loved one that's so far away isn't feasible for so many of these folks. And a number of patients actually reported the need for better accommodations for their loved ones when they're in hospital. As I just stated, that patient and her partner stating that she felt like she was a dog sleeping on the floor. There are a number of challenges around accessing accommodations in Vancouver when traveling, and there's a real lack of care and funding for travel for Indigenous patients coming from away as well. Travel services really need to address social, medical, and cultural needs for folks too. And many patients actually reported that they were discharged much too early. With so many patients being from away nations that are often very remote, there are only certain days where you can actually travel back home to get there. Different ferries, different planes, those types of things. And often we've dealt with patients who've actually ended up without a place to stay while they're waiting to go back to their homes. Having the opportunity to be much more careful with how patients are released from the system is incredibly important, especially when patients aren't able to be with their families. This next map was generated with a female patient in her mid-60s who had a heart attack, and she was medevaced in from Vernon. She visited the emergency department, cardiac, surgical, and she stayed in the hospital here for 65 days, and it well represents a number of key issues. People need cultural education. Most Indigenous women are modest. It's important for staff to remember to be mindful of patients' dignity and privacy. This woman stayed in a room with a number of men and stated, "Do not open a gown widely when examining. It can be very embarrassing. I didn't feel safe. I'm an Indigenous woman." Often the nurses and doctors would open my gown very quickly. Thank goodness the curtain was closed. During her time at St. Paul's Hospital, she found a number of interactions incredibly disrespectful. Her room was generally kept clean, but she changed her own bedding as it would go without changing for weeks. Changing her own sheets was very hard because she was weak and she had had a very serious surgery. She eventually obtained her own antibacterial wipes and wiped down her own bedside table, her nightstand, her bed, all of her belongings. She felt that any time I needed to ask for anything, even small things like a snack or a blanket, I was made to feel like it was a big deal and that I shouldn't bother the nurses. In the 65 days that I was at St. Paul's Hospital, I was only offered help to have a shower 2 times, and I only washed my hair once. I don't know about you, but for me, when I'm not feeling well, nothing feels better than being clean, having a bath, having a shower. I shower on a daily basis, and I know that I feel unclean, unwell if I'm not able to have a shower every day. I can't imagine going for 65 days without being able to feel clean. What I also need you to note here is that Indigenous people can experience regular healthcare encounters as racist, even if they are not. I need you to know that due to the systemic racism that has been widely encouraged throughout our society, our experiences are impacted and have been steeped in racism. So anything that's occurring, we're always fearing that we're being judged, that there's stigma around this, and that we're being stereotyped. I think that's a really important lens to have here as well, right? Just a simple eye roll. You know, if you're in the system, if you're somebody who goes in and actually fixes the machinery that's there, and or in a room with a patient, just a simple eye roll where you're actually thinking about, my goodness, you know, what's my patient or what's my partner making for dinner tonight? Or, oh, I've got to go and pick up some groceries, or, oh, I've got to go to the bank after work, or those types of things. That simple eye roll can be experienced by as an Indigenous patient as them thinking you don't want to be around them, or them being annoyed if you're asking, or if you're being asked questions, or you being annoyed if they're asking you questions. This patient very sadly passed away last September. Ed was a really wonderful human being. You can see in this image, he's wearing a purple sweatshirt. He and I really connected. He was a huge Harry Potter fan. I'm a huge Harry Potter fan. We had a really great conversation when we got started, which allowed us to have a really comfortable conversation going forward on this. This gentleman was in his mid-60s, 65 years old. He visited cardiac, the emergency department, surgical, and the ICU, and he stated that he had a mostly positive experience. I was born at St. Paul's Hospital in 1955, so the hospital has a special history to me. However, I've come to learn that a hospital is not necessarily a place to rest. He suggested that his vitals and blood work be coordinated so that they can be done at the same time and that there's less interruption leading to sleep deprivation. It was so cold in my room and they had me next to this big fan and it was so loud and all of the machines are so loud and they wouldn't turn it off. Isn't there a way that we can do what we need to support ourselves? I was so cold and I didn't want to ask anyone. I know they're so busy. He also stated that he would like to have deeper connection with care providers and talk more about culture and ceremony so they could be as seen as a person and not just as a patient. On one occasion, Ed stated that he felt disrespected when a heart specialist said to him, "Your heart stopped a couple of times in August. Did you feel it?" "Of course not. You were dead." Ed thought maybe this physician was trying to make a joke with him. It didn't feel like a joke. It didn't feel very safe for him. Ed also noticed a lot of the other Indigenous patients having a hard time while they were staying in the hospital. I know so many that have had their own trauma, things that they've seen or experienced or happened to them. It costs $0 to be nice to someone. Why is that so hard? Stereotypes and racism. It costs $0 to be nice to someone. Amazing that somebody actually has to make that statement. And honestly, how hard is it to smile at someone or to say hello, to treat someone like a human being? So many instances of stereotyping and racism or being thought of as less worthy. Alcohol users, drug users, all of the stereotypes that you typically hear about Indigenous patients being seen as inadequate parents. As a result of this stereotyping and racism, so many patients experience discrimination at the point of care, feeling like they're being treated differently, denied services, or being made to wait. And there are a ton of fears related to being stereotyped that actually negatively influence the patients, where they won't even seek care at all. I can speak personally to this. My godmother passed away 7 years ago now. She avoided care for so long because she was so fearful of what she would experience in the healthcare system that she didn't actually seek care until she was in too much pain. She ended up in hospital and had to stay in hospital for her last 2 weeks of life. I went and stayed with her every single night to help her feel safe, but she was ending her life in a place where she never felt safe or she never wanted to be. So many patients will leave care before they're actually done with the care that they need, and or they'll leave care before they actually receive care or not seek care at all. It's a true reality for so many Indigenous patients. And many patients from away are very nervous coming in. So many are coming in from communities that are 300 people or less. And so they react from a place of stress. It's important for people that are working with patients or interacting with patients or seeing patients whenever they're coming into facilities to understand what's actually impacting them when they come in for care. This patient, a female in her mid-50s, was seen in surgical and inpatient care. She stated, she's also an advocate in the downtown east side here in Vancouver. She stated experience with travel is a really prominent experience with some of the Indigenous patients' overall care. She noted challenges around accessing accommodations, a lack of clarity around funding. She also noted that travel services should better accommodate people's families and the different supports that they actually need in order to help them feel safe. So many of the patients, including this patient, felt that they were discharged too early without being part of that decision. They needed the space and they needed to discharge me. They do it so abruptly and often too soon. I was on oxygen and it was scary to go home and not be ready or be able to breathe well. And I ended up back in the hospital 2 weeks later because I was discharged too early. The patient who co-created this map also talked about needing to have access to Indigenous supports right away. There should be a knowledge keeper or an elder for all of the community resources available to a patient. So many people are discharged with no supports and nowhere to go. Discrimination and poorer care. Many patients reported that they didn't know what was going on with their care, and they noted that their interactions with medical staff were often short and that they seemed too busy, which gave the impression that they weren't worthy of those people's time. Some of the patients noted that there was a lack of basic comfort and care of needs for patients, including hygiene, right? Including having enough blankets or food or water. You know, oftentimes patients are coming in and they aren't coming in at times for lunch, breakfast, lunch, or dinner. They're coming in between those times or in the middle of the night, and they haven't been able to eat in hours, especially if they're coming from away. Many reported that they were really scared of asking questions or having the confidence to ask for the things that they actually need. And so many worried about prior experiences in the hospital, especially if they had utilized substance in the past, noting that they felt judgment or a lack of compassion. And many of the patients reported that they didn't receive any aftercare and noted that either postpartum or post-care that they could have used a lot more support. This patient just worked with in November of 2024. He reported, for 3 years, I've been getting these cramps, and I guess I thought they were just cramps. And I didn't think anything of it because if I drink water, it would go away. And then one night, it just wasn't going away. And then at 2 o'clock in the morning, I told my wife that I had to go to the hospital. And we went to Seychelles Hospital and they transferred me out right away. And we caught a ferry to St. Paul's Hospital. And I went for surgery and discovered it was diverticulitis. And I found out I'm diabetic. I didn't know that. And I have issues with my heart. And that's where it all started. And then 3 days later, I finally woke up and I couldn't breathe. They gave me oxygen. It took about 4 or 5 days before my breathing came back to normal after that. And then the bag, they put in a colostomy bag or a bag. They attached a bag because they had cut out part of my stomach, like 6 inches of the colon or something. I think it was the intestine. And then I had a hard time walking, getting out of bed. And the first day, they're like, you've got to get up. And they were trying to push me to get up. And the doctor had told me I wasn't supposed to use certain stomach muscles. And then they were like, you have to sit up. And they gave me a pillow to put on my back. And they said, lean against your pillow. I ended up leaning against the pillow and the pillow fell. And then I fell out of the bed. And they weren't worried about me. They were more worried about the wires and everything that was hooked up to me. And then I was just like, I need help. I need help to get up. And they were more worried about those wires being all mixed up and stuff like that from my arms and my chest and everything. And then finally, after about 10 minutes, I finally got up and leaned on one arm. And I told them I'm not supposed to be using my muscles in my stomach because it could rip out the stitches again. And they said, don't worry about it. Don't worry about it. And then the bag kept leaking and it kept going into the stomach and it was sticking to my skin. And then they finally got it figured out and I got out and I came back home and it started all over again. Throughout the whole time that I was on that bag for the 3 months, they said it was only going to be 3 months because the whole time I was in and out of the hospital, that bag was leaking. I ended up with so many infections. It wasn't sticking to my skin. It was 11 months of hell. And the doctor here told me I had to go to get a CT scan. And she said, you need a CT scan. And they said, well, let's get one set up. It could take up to 2 years. And I said, I'm not going to have this bag attached to me for I'm only supposed to have it for 3 months. And they're like, no, you need to have a CT scan before you can get the bag out. And I said, I'm not going to wear this for 2 years. And then when I had the bag, because it kept leaking, they didn't know what else to do. So they ended up trying all sorts of things. And I ended up having to come back to Vancouver and going out to New Westminster to a place where they have a ton of different types of bags. And they tried all of these different bags. And they finally ended up just using crazy glue to get it stuck to my skin. And contact cement. It was something that they used to do way back in the 50s and 60s. And then finally, they had to, when it was stuck so hard, when then they had to use a solvent to take it off. And it finally started to heal and my skin started to heal because I had a really large hole. The acid was eating my skin. When they finally got it all sorted out, they were able to do the contact cement to make sure that it wasn't impacting me as badly as it was before. The wait list for CT is so long, but to remove a colostomy bag that was attached to you when you're only supposed to wear it for 3 months, you'd think that would be a priority. And then I went back in May to get that removed. And I think it was in July when I went back for that CT scan. And the doctor called me. It was probably a couple of weeks after, and he said, okay, we're all done. You're doing well and you're healthy right now. So goodbye. Good luck. And so I thought it was good. And because he said it was all healed up and it looked good inside, I then got a call from the receptionist saying you need to come back for another CT scan. And I didn't understand why. And so I went in and they gave me the dye to go in my arm. I went in for the CT scan and I came back out, and then two doctors came out and said, why are you here? And I said, I don't know. They told me to come in for a CT scan. And they said, well, everything is working. We don't understand why you're here. And I didn't understand because the doctor I normally work with said we were all done. So I don't understand why I had to come back. And I was fine. We were all stumped. I'm not sick or anything, and I feel fine. There's no pain. The cramps are gone. So it turns out the reason that I had to come back is they hadn't canceled the scheduled CT scan that was there beforehand. The one that they were supposed to set up when I was able to get in early. All of a sudden you get a call for another CT scan. It was actually a mistake. All of this back and forth. And it isn't cheap for me and my wife. It's so expensive for us to have to come back and forth and booking hotels. And my wife was worried. There needs to be a better system around all of this. Communications and coordinations of care. Obviously, and you can see from that, the process needs to change, but it also needs to change so that people aren't afraid to ask questions. A few patients reported that patient-provider communication was good or excellent, but some felt like they were getting conflicting information from service providers, depending on who they were working with. The information didn't seem or seemed contradicting for them. Many patients also identified the need to strengthen the transparency, clarity, and completion of information. They didn't understand what they were being told or why, especially around their prognosis, around prescribed medications, around postpartum and antenatal supports, around post-operative procedures, around their lab results. So many of the patients noted the care that they received needed better coordination, especially around shift changes. And Indigenous patients often reported that they felt discriminated against because they were made to feel horrible about who they were as human beings, being denied medicines, being denied treatment, or made to feel like they were waiting for certain treatments as well. And it's important to recognize that there can be differences in how Indigenous people communicate, their styles of communications, and the behavioral norms. There are over 600 nations across Canada. There are over 200 here in BC alone. We all have different beliefs, different ways of interacting, different ways of communicating. And it's really important to note, just because you've learned a little bit doesn't mean you've learned enough. One of the patients reported our family doctor. She's admitted to mistakes in our care. And she said, hey, I took a shot and it was wrong. And now we're going to go this way and we'll fix it. We'll get you set. And that honesty of human error, that transparency, it made me feel even safer, even with the mistake. This patient, 30 years old, received care at a hospital here in Vancouver, and she stated that she had a mostly positive experience. I was planning on doing a water birth, but my contractions were coming in really fast, and the baby wanted to be out, and he was pushing down. It was only 4 centimeters dilated, and then they realized, because he was getting a little stressed out, his heartbeat was really high. I started to get really stressed out, so they pushed for an emergency C-section. That was really scary because I've never had one before, and everything was happening so fast. And while my contractions were happening, but they did a really good job delivering the baby. All of the nurses did really well. However, once I delivered my baby, I had a really unsafe experience. It was just after the same day I was in the recovery side, and I guess one of the nurses called for a social worker from Vancouver Aboriginal Family and Child Services for no reason. I was really shocked and I was scared because I was apprehended when I was a kid. Social workers, I don't deal well with them because of the trauma. And my support team, my older sister, she recently had her kids apprehended and she got her kids back, but she was feeling maybe they called because she was in the room. And that's what she said to me. She felt triggered. The social worker came to my room and introduced herself, and I asked her why she was here. And she was like, oh, you have no reason for me to be here. I'm so sorry that I came. My midwife, she looked into it. She said on the charts that one of the nurses called for a social worker. There were no other words. It just said, called for social worker, back fast. And we were trying to figure that out as well, because I have a great support team. I had two of my sisters. I had my support worker. I also had my a support worker for my 9-year-old son. After that, anyone who walked in the room, I asked what their role was. Because then I thought it could have been a social worker or somebody who was coming to take my baby away. This interaction caused me to lose trust in the healthcare system, and I'm already nervous. Advocacy and understanding. It's so important, especially when situations like this occur, that there is somebody to advocate for the patients. And while many patients report that they have a good level of understanding with what's happening in their healthcare journey, not all feel empowered to be part of their decision-making process, especially when situations such as a social worker coming into their room when they don't need to be there happen, or in areas such as discharge, follow-up of care, treatment of pain. There needs to be a real attention on the power imbalance that impacts their healthcare encounters as well. Patients also reported that they had a high level of satisfaction with the Indigenous Wellness Liaison Services to help them understand terminology, all of the different acronyms that are used in healthcare, and to be able to ask questions. So many different patients expressed the need to have more Indigenous people working in healthcare as well. This was actually a patient's mom. We worked with this patient. They were evacuated in from the Northwest Territories during the fires that happened here just over a year and a half ago now. This woman, 56 years old, her daughter came in and received care within the maternity area as well. This family was heavily impacted by the fires. Knowing that the Indigenous wellness team was there to look after my daughter, to keep in touch with me, it was like, you know what? That was comforting. We knew that she was going to be in good hands. Before I could get there, I heard that the moment she saw the liaison, her anxiety levels calmed. We're so far away and we couldn't be there at the same time to support her. Having the liaison there really made a difference given the challenges. I wasn't there yet. My daughter knew the job that the liaison was there to do, and they brought her a smudged blanket and some sweetgrass. Having Indigenous medicines, it was just very calming. My daughter got put on outpatient because they knew where they were going to induce her. So they made a list of appointments. So she went to all of her appointments as opposed to sitting in a bed waiting for the doctors to come to her. And she was close. She was only half a block across the street. So if anything went wrong, she was really close, and she really appreciated that. But when she actually went into the hospital, I actually appreciated she had a dedicated nurse in her room with her at all times. And I wouldn't have expected that. And I don't know if it was because of her condition or if that happens all the time. But I guess when they do inductions, there is a nurse. And if you want to chat, you could chat. And you could actually ask questions. I'd never seen this kind of care before. Her experience in the maternity ward, the people were amazing and they were genuine. And you could tell when they came in, they asked if she needed anything. They asked if she was comfortable. And one of the doctors literally sat with her for 40 minutes and gave her all of her options and let her be silent and think about it and waited. And instead of getting frustrated, just said, okay, if you want, I can come back if you want to think about it. And she then just sat there with her so that my daughter could ask questions. All of the doctors and all of the nurses, they just have really cool personalities and a sense of humor. You could tell they all get along. The Indigenous Wellness Liaisons. What I will let you note is in every single instance of these patient journey maps, we heard about the Indigenous Wellness Liaisons. They've had a very positive impact on patients. And they're able to provide respectful, identity-affirming care, emotional supports, spiritual supports, and links to any of the community resources or elder supports that they might need. Patients also reported that the Indigenous Wellness Liaisons were wonderful to work as advocates and connected them in with the healthcare providers, ensuring that they actually understood and were able to communicate appropriately or ask the questions that they were too afraid to ask. So many of the patients noted that they could have benefited from longer and more frequent stays with the Indigenous Wellness Liaisons, and several noted that they didn't even know that the services were available for them. This is a map that represents the story or the experience of a female in her mid-60s who was medevaced as well, and she talked a lot about culture and physical spaces. She felt she was able to always ask a lot of questions about medications and treaty rates. It was a strange environment. I did not feel threatened. However, there was a lot of activity. I did feel apprehensive, but I still felt safe and I could ask questions. And I also found out which questions and which nurses to talk to. This patient was given the opportunity to speak with Fiona Dalton, who is the CEO of our organization, who came to see her at her bedside. She reported that she felt heard and respected. I spoke with her about the difference between a registered treaty person versus any other First Nations person. I told her what I felt she needed to learn, and it was good to feel listened to. I felt very supported by Fiona. There were no barriers between us. She spoke with knowledge and with kindness. When asked what she thought could have been improved, this patient stated, you need to make sure that you account for the individual. Not everyone will want the same thing. You don't want to stop their healing and their feeling. You want to give them a hug or a support when they're ready. And while we're Indigenous, we're not all from the same nations. We need different things. She felt welcomed and taken care of and appreciated the liaison for connecting in and felt it was a good time to get used to the surroundings. The sacred space, we have an all-nation sacred space here at St. Paul's Hospital, felt like home. It was a nice feeling smelling the medicines, the sage, the sweetgrass, seeing the colors. The room had a nice feeling. And when they wheeled me back to my room, I was given a red blanket. I felt so special, so very happy. It was the first blanket I'd ever received from anyone. This patient stated, when I finally arrived for my delivery, I didn't know anyone. Who will be there? What will the delivery room be like? It would have been great to have someone there to fill in the gap, an Indigenous wellness liaison or some sort of person to ensure that I was supported to give the baby an Indigenous name and answer questions about teething, any of those kinds of things. It would be nice to have a guiding support. There was a social worker on the unit that helped with some things, but I was so overwhelmed at being responsible for the well-being of my baby alone. Culture, sacred spaces, and medicine gardens. Many of the patients expressed concerns that they weren't able to follow their own medical plans and really stressed the importance of culture and ceremony. It's so important to have a place for ceremony, a place for Indigenous peoples to go to feel safe, to feel familiar. So many patients reported they were appreciative of the sacred space if they knew it was there. And it was still challenging to access at times because it is in a location that is away from where the patient beds are. Many patients talked about how cold, clinical, and triggering the environments are within hospital facilities. And many patients reported that access to a medicine garden would actually provide many benefits to both the patients and the visitors, as well as the staff. This patient really spoke about the Indigenous wellness liaisons. This woman identifies as Métis. She's come to St. Paul's Hospital several times over the last 15 years, and she's visited various units such as the emergency department, the ICU, and Unit 10C. And overall, she spent many months here. She struggles with substance use and has dealt with many serious illnesses and related complications. This patient felt that she was stereotyped. She felt like she was not listened to. She was denied services, she was denied medications, and she was forced out of the hospital with what ultimately became a serious undiagnosed blood infection. In general, this patient had many negative and culturally unsafe experiences, including a lack of respect and abusive treatment by nurses and security. She stated, that weekend in the hospital was the most humiliating experience of my life. I had a colostomy bag, and it was attached to me, and it overflowed. And there was feces all over my bed. And I felt so dirty. And I let the nurse know that there was feces all over my bed. And she said she was really busy, but that she would come back. And she never came back. She didn't come back. I ended up being in my own feces for 8 hours. It was horrible. It was so incredibly humiliating. She did, though, eventually have a positive, trusting relational experience with her infectious diseases physician, who was eventually able to help her ultimately resolve some of her longstanding health issues. However, for her, the interactions with the Indigenous wellness liaisons were most impactful. I don't know what I would have done if I hadn't run into the liaison that day. It means a lot. It was a big help spiritually. I felt lost. The liaisons have given me hope again, and I don't feel so alone. Access to elders, to cultural services, to traditional medicines, so very important. So many patients reported that they wanted to have access to an elder or knowledge keeper during their stays within our facilities. So many patients also reported that they wanted to be connected to the Indigenous services earlier, to know that those supports are available so that they could feel like they would have the confidence to be able to ask questions or to have somebody to advocate for them as well. And so many patients mentioned that it would be wonderful for them, especially when they're staying in patient care, to be able to have cultural practices or ceremonies, such as cleansing ceremonies, drumming or traditional songs, options for birthing, naming ceremonies, and or ceremonies when somebody passes away as well. This patient, identified as a male from a First Nation on Vancouver Island in BC. He came to St. Paul's Hospital needing a kidney transplant due to renal failure. He had the kidney transplant in February of 2022 and has continued to visit St. Paul's Hospital for ongoing care related to his kidney transplant. For this patient, his experience was overall mostly positive. It was good. I got the best care possible. My social worker at the time for discharge arranged for another day in hotel, ferry reservations, and everything that I needed. It was very good. But he also had a bad experience during a transfer to another hospital, specifically around going blind while he was waiting for the transplant. They had to do some testing. And once the other procedure was done at the other hospital, I was left alone in the room. I couldn't see anything, and no one spoke to me or let me know that I needed to go or where I needed to go. I couldn't see. I was getting really scared. I just needed someone to help me. And after about an hour, I had to yell out to see if somebody could help to get me back to my driver. He let me know when I finally got back to him that that appointment took much longer than he had expected, and I laughed because boy, did it ever. He noted that the need for culturally safe experiences in care is essential for so many Indigenous patients. They healed my body, but my mind was a mess. I called and asked for a cedar brushing. I could not take it home with me. This patient also expressed concerns about making the care more patient-centric. He felt a lot of fear not knowing what was going to happen. It would be great if they could do a walkthrough the first clinic day or prior to you to coming to the hospital so that we know what to expect, what is happening. Private rooms would be preferred. It would be really great to be able to ask questions and to have the staff ask us questions about what we might need to find out where we're from and the most appropriate types of supports that we can actually get. Many of the patients also spoke about foods. Food is medicine for us. Prior to colonization, Indigenous people actually lived 15 years longer than they do today. A lot of that actually does have to do with foods as well. We lived in a very healthy fashion. Cultural foods are actually very healing and affirming for Indigenous patients. And specific foods can be a trigger or a source for trauma, especially for any of the patients that experienced care in Indian hospitals or in residential schools. Many of the patients actually felt it would be important to integrate foods into the setting, the actual healthcare setting. Right now here at Providence Healthcare, we're working on menu items and a system so that Indigenous patients can be assured that they will receive foods that are familiar for them as well. And many patients also express concerns about the food that they receive when special dietary concerns were present. There is an overrepresentation of Indigenous patients with diabetes and or different intolerances, foods that our systems still haven't grown accustomed to as they've been introduced from Europe as well. These intolerances caused so many patients. One patient who had diabetes and some other conditions, when she lifted the tray for her food, all she saw there was a rice cake. She looked at me and asked me, how is this healthy for me when I'm trying to heal? This patient and the final map that I'm going to share with you guys today from Cree Nation, 30 years old, was able to experience care in the emergency department and maternity. Her partner also shared information with us, a Squamish male, 40 years old. I was really scared of going to Vancouver to have my baby because I thought I was going to give birth here in Squamish. Squamish feels like my safe space. So I was already in labor. My water had broken in Squamish and I was planning on delivering here. And when I went and labored at home overnight, they called us in the morning, or they said to call us in the morning or call us sooner if things had progressed. And I called in the morning to be readmitted into Squamish Hospital. And they were like, we don't have a bed for you. So I was quite upset having to go down to Vancouver. When we arrived, I was quite pleasantly surprised with the care we were receiving up until after the C-section. It was all really positive, and then there was a night and day difference in the aftercare. The nurses were busy and seemed unhappy and sometimes slightly aggressive in the way they were handling my son. I was learning how to breastfeed, and they would come in there, and there was this one nurse in particular that I had to ask, can she not come in because I feel judged while I'm trying to learn how? I'm not from here, and I don't have any of my family here, the women of my family and our family. So that was quite challenging. And he's a first-time dad as well. And I didn't feel safe reaching out to the nurses to ask for their help because I didn't know which nurse I was going to get. Their ways of handling babies weren't consistent amongst each other, and their methods were also not consistent. I would have a nurse come in and say, what are you doing? He needs to be swaddled. You need to wrap him up like he's cold. And then I don't even know how to swaddle a baby. I'm a first-time mom. And then another nurse would come in and say, what are you doing? You need to do skin to skin. So it was very contradictory. And I'd been up for 2 days laboring, and I didn't sleep another night after that. So it's been 3 days that I'm up. I'm exhausted. I'm riddled with anxiety. And after going through that and processing the trauma of the birth, I didn't feel like when I expressed the desire for calming medication for myself, it wasn't met with like, oh, what you went through was really hard. And of course you would be feeling anxious, or you haven't slept in however many days. Instead, it was met with what I felt like was concern or judgment. So I don't know. It didn't feel like a safe space to be. Like I don't really feel safe right now. And it didn't feel like a safe space to advocate for myself. I was so exhausted and I had been through a lot. And I wondered if I would have been treated the same way if I was white. Medications and discrimination. Being met with concern and judgment when it should be things that are just very naturally given to patients. So many patients reported this same experience. So many patients felt judged and pick up on body cues, the body language, the eye rolls, sighs, things that you're maybe not even aware that you're doing. Patients also express the need to have a liaison or a support person with them during specific times of the healthcare journey to help bridge the understanding around medications, about the what and the why. Maybe there are specific reasons I'm not allowed to have that medication, but please be transparent about it. Discharge and aftercare. So many patients felt that they were well supported during the discharge process, especially when there was an Indigenous wellness liaison present. But so many also reported fear of expressing concerns about knowledge or a lack of knowledge of what to expect when they went home. So didn't ask questions and ended up back in care. And coming back and forth, as I've stated before, is incredibly expensive for so many of these patients. Many of the patients had access to services that they needed, and they expressed satisfaction with aftercare. However, many reported that they weren't able to access services in their home communities. And a few of the patients expressed that they did want to go home, but because of delays in reports or different things that they needed to do for testing, they were delayed. And so they were staying away from home even longer. So it's really important to consider the constraints of travel and supports for these patients, who, especially from OA nations. Now I'm going to share with you a few takeaways that I think are important to think about for your different practices here. There can really be differences between people's communication styles, and it's really important to know that not every person is the same. As an Indigenous person, I'm different. I celebrate different things than the people that I'm on their unceded territory. I'm not Musqueam, Squamish, or Tsleil-Waututh. They practice things very differently, communicate very differently than I do. Very important to advocate with your colleagues, right? To ensure that they're understanding the determinants of health and discrimination. It's so important to recognize that there are power imbalances in healthcare encounters as well. And it's really important for each and every one of you, all of us, to reflect on your own personal biases and the assumptions that you're making during any kind of interactions that you have with Indigenous patients. When we're thinking about specifically for your practices, important to take a look at unique needs. Consulting with Indigenous elders, right, to know if the designs and innovations around the equipment that you're working with are actually appropriate for some of the needs that Indigenous patients have. And designing medical devices and technologies for specific health issues that Indigenous patients are dealing with, especially in rural or remote communities. We think about the overrepresentation of diabetes or heart conditions. Developing health technologies that can actually support traditional practices and or therapies. We have our own Indigenous medicines, so many natural things that we actually utilize that so much of Western medicine is based on. and finding and developing solutions that can actually bridge gaps so that Indigenous patients are feeling like they do have an equal experience in healthcare, right? Having healthcare technologies and medical devices that actually can support that. Ensuring safe and effective use of medical treatments as well. So providing culturally safe training for any professionals who are involved with patients, ensuring that there are user-friendly medical devices that patients can utilize as well, that actually take into account potential language barriers or any of the diverse learning styles that we have as well. Implementing patient-centered care that are based on Indigenous values, focusing on collaboration where patients are involved so that they can actually make choices in their care as well. Developing portable and accessible healthcare tools that can actually be more easily used in remote or, as we've talked about in this presentation as well, under-resourced areas. Looking at medical units or low-cost diagnostic devices, creating telemedicine platforms that are actually enabled to work in remote communities where they have very poor access to Wi-Fi, right? So that they don't have to travel in for such long distances to places that feel so alien to them. Providing affordable and effective medical devices, ensuring that those tools are cost effective again, ensuring that all health data collected through these technologies is used ethically. Oftentimes as Indigenous people, we find that the data that's collected is actually used against us rather than finding out why these things are happening. The overprevalence of diabetes isn't because of the fact that we eat poorly all of the time. It's also because of so many different faculties. We are so much farther away. We don't have access to different medicines. We aren't used to a lot of the fast foods that are being provided now, easier or with more preservatives in them. Really important for considerations around promoting Indigenous representation and involvement as well. There are so many different opportunities. So are there ways for your faculties to look at supporting Indigenous students and professionals in biomedical and clinical engineering, or whatever area it is that you're working with? Can there be partnership opportunities for scholarships, mentorship programs? Indigenous patients have stated they want to see more Indigenous people in the healthcare professions, including these ones. Encouraging partnerships with Indigenous communities to help co-create solutions. Offering internships and or apprenticeships, also something really important to consider. And again, developing health monitoring tools very specific: diabetes, cardiovascular disease, mental health, just ensuring that there is a focus on these things that are common health challenges in these different communities, but finding out from those communities first, what are your priorities for healthcare right now? Ensuring that data analysis and machine learnings incorporate Indigenous health data, promoting equitable healthcare outcomes and more accurate healthcare delivery systems as well, and integrating traditional knowledge systems, allowing Indigenous practices to actually be recognized rather than as something that, well, you probably shouldn't be doing that. How do we work together on all of these medical treatments? Right. At this point, I'll stop the conversation or I'll stop speaking and see if there are any questions from anybody.
That was an incredibly powerful talk. Thank you very much. Anyone who watches us knows I don't typically stumble over my words. So I think that in and of itself tells you how impactful that was. And I really like how you highlighted, because I never actually would have considered this before. Recently, like last year, and we've heard some horror stories, etc. But to hear just how endemic and even more than typical, it's every time. I never would have thought of that. So to have that for our context and help us to deliver our support of care, because people will often hear me say, although we're on the technical side, that's my patient too. So the little bits that we can do in what we do, moving through spaces, etc. Thank you very much for that context. And I can tell you, in various more modern redevelopment projects. For instance, ours here in Halifax, I'm very happy to say we are designing into the space not just your typical multi-faith kind of spaces. We have smudge-friendly spaces. Um, we're seeing transition to care facilities where you're not just put right on the street. So your poor patient who is still on O2, no, you're not just put to the curb. Like there's different supports being put in place, which is a wonderful shift in overall care. But I really like how you focused for it that it's definitely not a one size fits all. And there are some really specific and what folks may not realize needs from our First Nations. I say cousins. I'm large part Acadian, so I see First Nations people as cousins because we lived for quite a while in wonderful harmony before things changed. Um, so thank you very much. It and very, very impactful. I will shut up so that Becky can read some questions and we get to that. But
Yeah,
thank you.
thank you, Michael. I appreciate that. It's important for people to hear about things that are being done already, to know that it's not impossible to do this work. There are steps that you can take to move forward to create more culturally safe experiences for Indigenous patients. Absolutely. So thank you for your comments.
Thank you, and thank you, Sheri, for a very informative talk. I'll start with a question of my own. I was wondering, outside of a context like this webinar, which has been very informative to all of those of us who are able to attend, how else is it best to user distribute the patient journey mapping information that you've gathered?
Like how are we utilizing the patient journey mapping information that so it's been really wonderful. We've actually now are working very specifically on improvement projects throughout our healthcare organization. So we've been able to work with Road to Recovery, which is a program that really focuses on recovery from substance use. We've done some really important work with them to help design the program from an Indigenous perspective, right? Everything from what the rooms look like to the care that's being provided to the different programming that's provided as well, which is traditionally based on like a 12-step program, which is a very Christian program as well, right? We've also worked really closely with our pregnancy, birthing, and newborn area. You noted there were a few of the maps were from that area. And we were able to create an actual change one of the meeting rooms to make sure that it's a ceremonial space for naming ceremony. Each one of these allows us to actually create these improvements and bring light to, what people aren't aware is still occurring, right? And I think that's one of the things is each area that we've worked with, and I can't even tell you how many of these presentations I've done now, people come back to me and say, I wasn't aware it was still occurring, or I recognize that patient, and it's so important that I'm able to hear this feedback because I can then actually make changes to my practice that I was unaware of beforehand. So I think that's probably the best example of how we're utilizing the maps is just, working with each of these departments individually so they can start to think about and work with us, the Indigenous Wellness team, as well as the community to find ways to make improvements so people are feeling safe within the system. Does that answer your question, Becky?
Yes, definitely. Okay, I'm going to go to the question and answer box here. So a bit of a high level question from Ryan. Thanks for the information you've shared. Is there any suggestions you have for support staff on how we can support this patient population?
Yeah, absolutely. And I think when we think about support staff in all of this work, as Michael had stated beforehand, these patients are your patients as well. Knowing as much as you can about the nations that are where you are, knowing what can potentially impact them, educating yourself as much as possible, getting to know folks. And then when you see any interactions, if you happen to go into a hospital facility, or if you happen to be, fixing a piece of machinery or whatever that looks like, whatever your role is, knowing that it is part of your role to actually advocate for the patients as well. Even making suggestions, you know, when you see something or hear something from a patient, is there a way that we can improve that piece of technology? Is there a way that we can, you know, improve, help to improve the way that physicians are communicating with patients, or whatever that looks like from your role? I think there is no end to things that can be done. And I think having these discussions and even starting to think about those different things that I shared at the end of this presentation can support you in thinking about how you can make a difference as a support person as well.
Becky, do you mind if I jump in with a thought?
Please do.
So I participate on the subcommittee that's led by Martin Poulin for international outreach. I wonder, Martin, maybe you can put your thinking cap on, if we can do a Canadian outreach. Because I happen to know I'm originally from New Brunswick, and my father actually had to take advantage of the telehealth solution that they have in place for post cardiac care. He had a double cabbage as well as mitral valve, and because of it's in a suitcase, goes home with you. There's a video, there's SpO2, ECG, and a BP, all wrapped up in this little suitcase, which you connect through, and then the nurse who's central checks in and actually saw an infection starting in his chest wound, etc. So he went for care, etc. Can we, with our technical brains, think of reapplications of technology that we have in our various spaces? And okay, now how do we launch that for something that's super remote? And it's not just hey, we can have the best whiz bang technological application, but only if you have really good Wi-Fi. Like we're reasonably smart people in this community. How about we put some thought to actually come to really serve all of our patients? Because really we have patients right across from coast to coast to coast. Just a thought.
Thank you for sharing that, Michael.
Great, Michael. And some of you may know I'm originally from Brazil. Maybe I can give an example from there. A hospital, the largest hospital in São Paulo, they created a program where they do prenatal exams, ultrasounds in the indigenous communities by empowering the indigenous folks to actually work with the ultrasound device, and it's connected remotely to the doctors in São Paulo. So they're able to reach a lot of those communities. A lot more babies are being born healthy now, and the mothers are having the care they need without having to move away from where they live, right? So it's a really good example of we can make it work, and it's with 5G.
Great example. Thank you for that, Alice.
Great. Moving on to another question here from Philip. How do you separate actual racism versus poor experiences that are a result of a system that is overstressed?
That's an interesting question. And I think the two do tie in together, right? And we often hear, and I think maybe this is a better way to look at things. Indigenous patients are experiencing, and I had stated beforehand, they will experience things that are maybe not racist per se, but experience it as racist because of what happens throughout the whole system and because of what's happened historically and is ongoing with anti-Indigenous racism. I think what's a better way to look at things, and what I've heard from quite a few of the healthcare professionals I work with out here in BC, is if we could just do these things for every patient, it would be such a better system. So instead of trying to separate that, going with the people that are actually experiencing the lowest common denominator of care and focusing there and saying, look, we need to improve this, we need to improve this, and we need to make sure there's equal access to that for everybody.
Thank you. And there's another question here, which I think is right along the same line. So I'll just read it, and if you had anything to add. So just summarizing that this presentation highlights how much our healthcare system is failing Indigenous people, but there's also many of these concerns which are for other Canadians too, especially rural Canadians. So we all know our healthcare system is stretched to the limits. How do you see this moving forward for both Indigenous people and other Canadians? I think if you had anything to add on that.
No, I think that's, you know, it's very true. Right? Like, we all know that our healthcare system is incredibly stretched, and, you know, there are different challenges happening in the world right now that I'm not going to even allude to, because it gives me a headache every time I think about what's happening south of the border right at the moment. So maybe I just gave too much information there. You know, it's these challenges are going to be ongoing, but it doesn't mean that we don't all deserve to be treated as human beings within the healthcare system. So I think that's a really important factor to just keep underlying all of this. There are ways to move forward, even with, you know, the monetary constrictions we have across the country, really, when it comes to this. And healthcare is not always a primary focus for a lot of the governments across the country too. So how do we work within those constraints to just make services better? Yeah.
Thank you. Question here from Ryan says, are there any opportunities to volunteer for Indigenous communities, especially if it's in regards to support staff needs, like the way there are volunteer opportunities like Engineers Without Borders?
I'm sure that there probably are multiple opportunities with that. I think really great. Almost every nation across Canada has their own websites, and they'll have chief and council who you can get in contact with. There are oftentimes, you know, I work with nations all across BC, and we're building just a really good example. We're building a long-term care facility with Providence Living right now up in northern BC, and I'm working with the Lheidli T'enneh to try to partner with educational facilities so that they can actually now staff that long-term care site with Indigenous employees from the nations up there, right? So how can you partner together in order to set something up? So I think reaching out to the nations, reaching out to Chief and Council, they'll take your emails. They'll have a general email, and they actually do respond to that in most areas. If not, they'll have ways that they like you to reach out, and we're always looking for ways to partner together to make things better, right? Yeah.
Maybe just a couple more minutes left in our time for today. Any further questions from Michael or Alice? No? Okay, well,
No, I think
go
that
ahead,
last
Michael.
question really went along with kind of the inspiration. I wonder what we can do more on our own soil just to use our creativity to benefit more people. So there you go. More than one person was thinking about that point. I will highlight, I love that you essentially I use mind mapping fairly frequently. So when I see that, me being such a visual person, that resonates so well with the way you did really encoding that information to almost viscerally transfer the information so you can appreciate better. Then, okay, there's a whole bunch of black and white text. Great. And then you skim over part of it and it's blah, 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 blah. So, no, 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 no. This really hits home. So I love how you do that documentation.
Thank you. And I will state that we've heard that from the patients as well. So many of the patients have stated, because the maps are drawn while they're speaking right in front of them. And so the artist works there and is always checking in with the patients to make sure that they're feeling like it's representing them in a good way. So many have stated it's the first time they've ever actually truly been heard as well. So it's a really wonderful way to humanize.
I would think a lot of tissue boxes would be required for those interactions.
Yeah, you know, it absolutely, there are some incredibly difficult experiences that are
Absolutely.
shared, for sure. Yeah.
It's wonderful to be heard.
Well, with that, I think we'll draw today's webinar to a close. So Sheri, thank you so much for sharing all this information with us. And we see your email up on the screen. So to all those in attendance today, please feel free to contact Sheri for feedback, questions, or ideas, as she says. And again, this webinar will be available on the YouTube channel if you would like to share with anyone that wasn't able to attend today.
Thank you
So-
so much for having me here today. It was really wonderful to be able to work with this group in particular as well.
Thank you so
Great.
much for being here today and sharing your wisdom and thoughts and helping us all eventually to achieve two-eyed seeing.
Have a
Okay.
wonderful rest of your day.